Okay. You can start whenever you're ready. I'll edit out the first part of it anyway. Thanks.
Okay. One second, let me just organize my keyboard here. Hi everyone, my name is Laila Najia and I am one of the PGY2 cardiology residents at University of Maryland. Today my pharmacotherapy rounds are on new cardiac medications. Will they fill a gap in care? I think this topic is very important because as more and more cardiac medications come to market, we really need to figure out if and when we should use these medications. As a reminder, for meds to be approved to come to market, they really just need to be relatively safe and somewhat effective. So it's really our job as pharmacists to determine if and when we should start these in our patients. I will be discussing 4 medications: finerenone, vericiguat, tafamidis, and selatogrel, 3 of which are undergoing phase 3 trials currently, and 1 is already approved. Jumping right in, the first medication we're going to talk about is finerenone. It blocks the aldosterone at the mineralocorticoid receptor. Other mineralocorticoid receptor antagonists, or MRAs, on the market include spironolactone and eplerenone, and they're indicated in patients with heart failure with reduced ejection fraction, or HFrEF, because they decrease mortality. However, oftentimes their use can be limited by the hyperkalemia that they cause. Additionally, aldosterone has some harmful effects on our kidneys, and therefore there may be some role in patients with diabetic nephropathy. First, I just want to give a better background on the hyperkalemia that is associated with these MRAs. The data in front of you is from the CHAMP-HF registry, which is a registry of patients with HFrEF who had at least 1 medication for heart failure. In the MRA column, you can see that 66% of patients were not started on MRAs. And when they looked at why, they found that it was anyone who was somewhat older age, over 60, and had any kind of renal dysfunction. And you can see in that group with renal dysfunction, 50% had an EGFR greater than 60, which is perfectly fine to put someone on spironolactone or eplerenone. So a lot of it was fear of this risk of hyperkalemia. The next trial was the TopCat trial, which looked at spironolactone versus placebo in patients with HFpEF. And as you can see, the hyperkalemia rates were double in the spironolactone group versus placebo, and potassium greater than 5.5 was significantly higher in the spironolactone group, and that was despite being on the lowest dose of the medication. So this brings us to finerenone. It is a non-steroidal MRA that has increased mineralocorticoid receptor selectivity compared to spironolactone and eplerenone. It also has equal concentrations in cardiac and renal tissue compared to spironolactone and eplerenone, which have increased concentrations in renal tissue. This difference of activity is the reason why finerenone was hypothesized to have less hyperkalemia associated with it. We know blocking aldosterone can be important in patients with heart failure because aldosterone can lead to left ventricular hypertrophy, fibrosis, ACS, ischemia, AFib, and congestive heart failure. But we also know that it's important in patients with renal failure because it can lead to renal fibrosis, proteinuria, and chronic renal failure. Finerenone was studied in 3 phase 2 studies, and that includes the ARTS studies. It was compared to spironolactone, eplerenone, and ACEs and ARBs, and it found that there was really no clinically significant difference in potassium or EGFR decline. In 2015, the FINESSE-HF trial, which was supposed to be a trial of HFrEF patients with type 2 diabetes and/or CKD, was due to begin enrolling patients. However, once they saw that there was really no clinical difference in this rate of hyperkalemia, they decided to focus their efforts on diabetic nephropathy, and they ditched this trial. And that brings us to the 2 phase 3 studies that we have on the market, Fidelio and Figaro. These studies are pretty identical in their inclusion criteria in that patients had to be stable on treatment of ACE or ARBs for at least 4 weeks, have type 2 diabetes, and persistent albuminuria. Patients were randomized to finerenone 10 to 20 milligrams daily or placebo. And the differences in these trials was based on their primary endpoint. Fidelio had a primary endpoint, which was a composite of renal failure, decreased EGFR from baseline, or renal death, whereas Figaro was cardiovascular endpoints like CV death, non-fatal MI, non-fatal stroke, and hospitalizations for heart failure. Of note, Bayer released a statement that Fidelio met their primary endpoints, but there's no results to show. So overall, for finerenone, we need to wait until better data comes out to determine its place in therapy for patients with type 2 diabetes and moderate CKD. There is one additional trial for finerenone, and that is the Fine Arts study, which is a phase 3 trial to assess morbidity and mortality in patients with HFpEF. And hopefully this gives us a better idea if MRAs should be used in this patient population. In the meantime, since we can't do anything different with our patients with type 2 diabetes and CKD, we can put them on therapies that we already know to slow the progression of CKD. And that includes ACEs and ARBs, SGLT2 inhibitors, and GLP-1 receptor antagonists. So in short, for finerenone, its hope was to come to market and be able to increase MRA use in patients with HFrEF. And when there was no difference in potassium, they kind of ditched that idea. So now there's a potential for its use in type 2 diabetes and CKD, and potentially for patients with HFpEF pending these phase 3 trial results. In the meantime, it's very important that we just optimize guideline-directed medical therapy in the patients we have. Speaking of optimizing guideline-directed medical therapy, the next drug we're going to talk about is trying to add on to our GDMT train for HFrEF. Yes, this is vericiguat, and it is another HFrEF medication coming to market. You may be wondering why there are constantly so many drugs for HFrEF coming out, and while it's because mortality in these patients is very high. 5-year mortality is anywhere from a fourth to half of our patients, and that is despite guideline-directed medical therapy. There are constantly drugs coming to market with novel mechanisms of action to try to bring this mortality rate down. So that brings us to vericiguat and its novel mechanism of action. Before we talk about that, I just want to go over regular pathophysiology. This is the soluble guanylate cyclase receptor, and our endogenous nitric oxide will bind to it, and that will lead to the production of cyclic GMP. cGMP is important for normal cardiac function as it leads to myocardial relaxation and vascular vasodilation. However, in patients with heart failure, it's a pro-inflammatory state with oxidative stress from circulating reactive oxygen species. And this leads to less of our endogenous nitric oxide binding to our receptor, which will decrease the concentrations of cGMP, and that can lead to myocardial dysfunction, impaired contractility, and abnormal rate and rhythm. Vericiguat will bind directly to this soluble guanylate cyclase receptor, and that will increase our concentrations of cGMP alone. Not only that, though, it enhances the sensitivity of our endogenous nitric oxide to bind to allow more cGMP to be produced. And aside from all these hemodynamic effects, it also has direct antifibrotic effects on our cardiac myocytes. The Victoria trial was the study that looked at vericiguat in HFrEF patients. It looked at patients with NYHA class 2 to 4, and they were randomized to vericiguat 2.5 milligrams daily to a max of 10 milligrams and compared it to placebo. The primary endpoint was a composite of cardiovascular death or heart failure hospitalizations. Patients in the study were fairly well controlled at baseline, especially compared to our CHAMP-HF registry. Almost 90% of these patients were on ACE, ARB, or ARNI, 70% were on MRAs, and 93% were on beta blockers. The primary endpoint was significant with a number needed to treat of 24 and a benefit seen around the 3 to 4 month mark. However, when they looked at other endpoints, they found that there was no difference in cardiovascular mortality alone, no difference in heart failure hospitalizations alone, and there was one other composite endpoint of all-cause mortality or heart failure hospitalizations that was significant. Because this cardiovascular mortality alone endpoint was not significant, it's pretty difficult to say that vericiguat leads to mortality benefit, and therefore it might only be able to help with reducing heart failure hospitalizations. So this will bring us to our first patient case. We have a 67-year-old white male who's here for routine follow-up. He has a history of HFrEF with NYHA class 3 symptoms, and that's despite adherence to his medications. Of note, his labs are all within normal limits, and these are his medications for his heart failure. The sacubitril valsartan, max dose, metoprolol succinate, max dose, and spironolactone 25. So would vericiguat be the next medication to add on to this patient to optimize therapy? In my opinion, I would say no. I think we have another class of medications, the SGLT2 inhibitors, which we know do decrease mortality. And so when you're adding on another agent, it's important to try to decrease mortality first. So this brings us to a special segment where I get to pretend I'm on the AHA-ACC guideline writing committee. It's been a few years since our guidelines were last updated, so I figured I'd give it a whirl. Some new updates from the last time the guidelines were published is the addition of the SGLT2 inhibitors for our HFrEF patients with NYHA class 2 to 4 symptoms, and vericiguat, which is likely going to be approved in January of 2021, and it will likely be for NYHA class 2 to 4 symptoms. I'm predicting at least. So the question is, with so many medications on the market, how do you determine what order to put them in? Well, let me introduce you all to the GDMT train. This train is the train that decreases mortality. It consists of your beta blockers, your ACE, ARB, ARNIs, your MRA, and your SGLT2. These 4 classes are so important to have on early because they can help decrease mortality. Bringing up the caboose is the addition of hydralazine nitrate, which can be used in patients who are Black or of African American descent to further decrease mortality. So then we have the honorable mentions. Those are the medications that don't decrease mortality, but we could potentially use them. We have loop diuretics, which are purely for symptom control, and a lot of patients are on these. And then we have other medications like digoxin, avambridine, and I would put vericiguat here. Could be helpful with symptom control, but could also help with possibly reducing heart failure hospitalizations. No mortality benefit in these though. And vericiguat had one more trial, that was the Vitality trial with NYHA class 2 to 3 symptoms. It randomized patients to vericiguat or placebo, and the primary endpoint was KCCQ scores from baseline to 24 weeks. I thought this was an interesting but appropriate endpoint. We know no medications currently reduce mortality in patients with HFpEF. However, vericiguat works on the same mechanism as some other medications that were already tried and failed. That would be the NEAT trial, which was isosorbide mononitrate versus placebo, and the RELAX trial, which was sildenafil versus placebo. And both of those failed in improving quality of life or exercise tolerance in patients with HFpEF, which got them a class 3 recommendation of no benefit. Of note, the results of the Vitality trial was submitted on September 29th, and the FDA actually just released a statement saying that there was really no difference between this, and so it's likely not going to be used in this patient population. So overall for vericiguat, its goal for coming to market was to help reduce morbidity and mortality in our patients with HFrEF. It doesn't look like that's going to happen. And in terms of HFpEF, we are awaiting the full results of the study, but it doesn't seem like this will actually help decrease mortality based on the preliminary results that were released. This next medication is the only medication that I'm going to talk about that is actually approved and on the market. The reason I wanted to include this is because not many people actually know about amyloid cardiomyopathy, and probably even less know about this life-saving medication, which is tafamidis. So to start, what is amyloid cardiomyopathy? Well, it's a type of restrictive cardiomyopathy that's caused by amyloid fibrils, which are a misfolded transthyretin, or TTR, protein, and that deposits into various organs in the body. Commonly, patients will first start to complain of symptoms of peripheral neuropathy, and that can include carpal tunnel or numbness in their lower extremities. And while cardiac involvement is not common in these patients, it is the biggest predictor for mortality, with about less than 6 years to live without any kind of medication involvement. Early diagnosis in these patients is very important because we currently don't have any medications on the market that truly reverse this amyloid. We just have things that can help prevent it being deposited, like tafamidis. It is a TTR stabilizer, and that will prevent new amyloid from forming. So the earlier the diagnosis, the better the outcome in this patient population. Also, a good thing to note is that these patients will also present with the generic symptoms of heart failure like dyspnea, fatigue, syncope, orthostatic hypotension, but our normal GDMT does not work in this patient population. The ATTRACT trial was the study that got tafamidis approved. It looked at patients with confirmed cardiac involvement who had a history of heart failure and had NYHA class 1 to 3 symptoms. As you can see, class 4 was excluded from this trial, and it's likely because tafamidis wouldn't really have a huge benefit in that patient population since they've already had a lot of this amyloid being deposited. Remember, tafamidis doesn't reverse what's deposited, it just prevents new from being added. The intervention was tafamidis 20 milligrams daily versus 80 milligrams daily versus placebo. The primary endpoint was all-cause mortality and cardiovascular-related hospitalizations. Tafamidis was found to be superior for all-cause mortality with an benefits seen approximately at 18 months, and it also found an increased quality of life by slowing decline in 6-minute walking distance and KCCQ scores. And there was a subgroup analysis that compared the 80 milligram dose to the 20 milligram dose and found that 80 milligrams can decrease mortality and hospitalizations, where 20 milligrams looks like it might only help decrease hospitalizations. So overall, tafamidis is approved for amyloid cardiomyopathy patients with NYHA class 1 to 3 symptoms. And we talked about there being two doses, the 80 milligrams and the 20 milligrams. But this medication is extremely expensive, with an average wholesale price of $225,000 per year. Oftentimes, insurances won't cover that 80 milligram dose since it means taking 4 capsules of the 20 milligrams, and that's because it was only found to be different in a subgroup analysis. Because of that, patients' insurances weren't covering it, so patients weren't receiving that dose, which is bad for our patients, but also the drug company, of course, was losing money, which prompted them to create this other version of tafamidis, a different salt that is 61 milligrams and is supposedly equivalent to this 80 milligram dose. For that reason, I hope that our insurance companies will cover this dose and more patients can get on the better regimen. So this brings us to a patient case. We have a 70-year-old white male with newly diagnosed amyloid cardiomyopathy. He's having increased shortness of breath, fatigue, and edema in any of his activities of daily living. He's diagnosed with NYHA class 2 symptoms along with this amyloid, and he's started on tafamidis and the glutamide 80 milligrams daily. Your team wants to know what the benefits would be in this patient. Is it A, decreased hospitalizations, B, decreased mortality, C, improved quality of life, or D, all of the above? And the answer is D, all of the above. Tafamidis can help in all 3 aspects. It came to market because of its hopes to decrease morbidity, mortality, improve quality of life, and that's exactly what it did. In patients with amyloid cardiomyopathy, it's very important we diagnose them early, since there is a clear benefit of earlier treatment in these patients having better outcomes. The idea of early treatment leading to better outcomes is what the next and final medication is trying to accomplish. That medication is selatogrel. It is a novel P2Y12 inhibitor intended for patients who have a prior ACS event, and the idea is to further reduce ACS events. Despite all of our improvements we've done with ACS management, including decreasing the thrombogenicity of our stents, approving better generation P2Y12 inhibitors, decreasing door-to-balloon time in our ACS patients, the rates of recurrent events still remains pretty high. In 2020, there was 335 recurrent MIs, and the annual incidence is predicted to be about 200,000 each year. As you can see, based on age and gender, your rates of recurrent events can be anywhere from 11 to 45%. And that's despite our best efforts to keep these numbers low. So can selatogrel potentially help? Well, it is intended for patients with prior MIs who feel a new MI coming on, and it's to be self-administered, similar to an EpiPen, to have sooner peak antiplatelet effects around 15 to 30 minutes. The inventors of selatogrel believe that there are a few limitations to our current oral P2Y12 inhibitors. The first one is the time to peak effect. Their argument in all their papers is that it takes upwards of 6 hours for a peak effect for our P2Y12 inhibitors, and well, we know that's just not true. We know Plavix without a load, sure, it could take up to 6 hours. However, with a load, it's down to about 2 hours. And our newer generation P2Y12 inhibitors, prasugrel and ticagrelor, have about 2 hours before their onset. And then with a load, it could be even shorter. As we know, any patient presenting with ACS should always be reloaded, and that will help decrease the time to peak effect. The next argument the inventors of selatogrel made is that our oral P2Y12 inhibitors have a drug-drug interaction with morphine, and that other opioids, which can lower these concentrations of drugs. And that's true, but I think I have an easy solution for that. We all know this algorithm, we learned it in school, it was part of our board exams, but there is one giant problem with this. It contains morphine. Morphine does have a pretty significant interaction with our P2Y12 inhibitors. It can decrease the absorption of these drugs by over 30%. Not only does there this interaction, but the use of opioids in patients with ACS is non-diagnostic of their underlying pathophysiology. Oftentimes, we can have patients who present with NSTEMIs and they don't go to the cath lab right away. And sometimes the ongoing presence of chest pain can be the deciding factor if they need percutaneous coronary intervention, PCI, or not. If you give them an opioid, you could be masking their pain, and that's not going to tell us anything about their underlying infarct, whether it got better or worse. And so for that reason, it's really important not to mask pain in these patients and to treat with something like nitroglycerin, because we know ongoing chest pain on the presence of nitroglycerin could mean a trip to the cath lab. These are two very important things, if nothing else, when talking about selatogrel. It's just management of patients with ACS and ongoing angina to avoid opioids. Okay, I can hop off my soapbox now, and we can talk briefly about the phase 2 trial that that has been done for selatogrel. And so it was a PK/PD study for patients with chronic CAD, and they were randomized to selatogrel sub-Q or placebo. And their primary endpoint was platelet response or P2Y12 reaction units less than 100 at 30 minutes after injection and lasting at least 3 hours. Just for reference, a PRU less than 180 is evidence that the P2Y12 is effective. Over 80% of patients in this study had a prior PCI, and almost all of them were on aspirin at baseline. And what they found was that selatogrel had a platelet inhibition about 15 minutes. It sustained for about 8 hours and then was reversed by about 24 hours. In terms of safety, there was increased dyspnea and increased injection site bleeding in the selatogrel group versus placebo. So overall, I think that there's some potential limitations of this medication, especially on educating how to administer and when to administer this medication. There are a lot of benign disease states like GERD and heartburn that could mimic a heart attack, so maybe it's not best to leave it up to a patient to determine that, especially since injecting a P2Y12 could increase the risk of bleed. And then in the meantime, while we wait for phase 3 trials of this drug, it's important to optimize our current practices, which is cautious use or avoiding use of morphine in patients who have ACS and administering appropriate loading doses of our antiplatelet agents. So in summary, there's just some major things I wanted to highlight about this presentation. Just because a drug comes to market does not mean it's appropriate for our patients. We do need to consider what current treatment options are on the market and if this new medication truly has a place in therapy. An additional thing to consider is that cost of new medications can be very expensive. And as my excellent preceptors here have taught me, there is such thing as financial toxicity, and that adding new medications can impact our patients' lives financially, mentally, emotionally. So it's really important that we choose medications we feel have the greatest benefit in them. So in short, for finerenone, we want to optimize our cheaper medications we already have on the market to help slow the progression of CKD in patients with diabetes. For vericiguat, we should be holding off the use of this until we have optimized our GDMT, remember my train, and then if they continue to exhibit ongoing symptoms, we can reevaluate what medication to add on next. Tafamidis should be initiated as soon as possible in patients with amyloid cardiomyopathy. Yes, it's a very expensive drug, but you really can't put a price on life. And so the earlier the diagnosis and the earlier the treatment, the better their outcomes are. And lastly, for selatogrel, it's for our patients with ACS. In the meantime, while we wait for trials for this drug, we can just have better ACS management in these patients, and that includes opioid avoiding and loading our P2Y12s. And with that, I will take any questions you guys have. Sandy, I think I'm done. I don't know why I said I can answer questions. There's no one here.